But I'm primarily focusing on and summarizing, reviewing the high points of the 2021 guidelines put out by the American College of Cardiology and the AHA, with also some from the 2025 guidelines for the management of ACS.
Minimize everyone's faces.
Let's see. Okay, objectives for this talk. I want you to be able to recognize the high-risk features of chest pain. I want you to understand the options for testing in intermediate risk cases. Know the non-cardiac causes of chest pain, or at least have seen them to keep in your differential. And by doing these things, we will, of course, profit. All right, so introduction, CAD affects 18.2 million adults in the U.S., remains leading cause of death for men and women. Over 365,000 deaths annually. It's the second most common reason to visit EDs behind injuries. However, of all ED patients with chest pain, only 5% about will have ACS, and more than half will ultimately be found to have a non-cardiac cause. Important to know ACS, but you got to know the other stuff as well. There's a heart. Some definitions. So for when we say CAD, when I say CAD, coronary artery disease, of course, the guidelines, these may be different elsewhere, but in the guidelines, they say for obstructive CAD, that's at least 50% stenosis, and non-obstructive is less than that. High-risk CAD refers to when we have that 50% stenosis in the left main or 3-vessel disease. All right, so starting off with a case. We have a 50-year-old male, history of CAD, hypertension, cholesterol, tobacco use. He was admitted yesterday to our service for influenza pneumonia, resulting in hypoxia, currently on 2 liters. We are treating with Tamiflu and supportively trying to wean oxygen. You are paged in the middle of the night, cross cover. Nurse pages that the patient is complaining of chest pain. What's your next step? Yeah, okay. I like that's your first thought. We'll get to there. But how about let's go see the patient first. Gotcha. Yeah. You go and see the patient. Get it. You want to get a history. Chest pain can be a lot of different things. But this patient describes chest tightness of sudden onset, awoken from sleep, pain radiates to the left jaw, nausea and dyspnea with it. On exam, uncomfortable, pale. Are we concerned? Yeah. As Elon Musk says, extremely concerning. So first off, chest pain, when we hear chest pain and when we're thinking about it as it relates to coronary disease, classically, you hear this substernal chest discomfort provoked by exertion or emotional stress relieved by rest or nitroglycerin. Important to distinguish between acute and stable, or acute and chronic. So acute is obviously new onset or involves that change in pattern, intensity, or duration. So when someone describes chest pain to you, make sure to ask, hey, what is this similar to previous episodes of chest pain, or is this new? Stable, as we said, is chronic and can be associated with consistent precipitants. Other thing to keep in mind when we have chest pain, it doesn't always refer to the chest, and patients won't always describe it as pain. Symptoms can, of course, affect the shoulder, arm, neck, back, abdomen, or jaw. And they, instead of pain, we get those that tightness, pressure, squeezing, heaviness, or burning can all be described. So clicking like this guy. All right, I like this chart from the guidelines. Probability of ischemia kind of based on the descriptions of the chest pain. So when you have your concerning chest pain, you hear all your buzzwords, the pressure, gripping, heaviness, tightness, substernal or retrosternal. If they're describing this dull, aching, stabbing, of course, it still can be ischemia, but can also be described with other things. Tearing and ripping, less likely ischemia. Those are concerning for other reasons. And then, of course, if we have sharp or pleuritic, we're much less likely to be ischemia. So I like this. That's a good, helpful chart there. So in our case, yeah, like you guys said, EKG and troponin with this concerning story. You're also probably going to get basic labs. all right, you get your ECG, and I'm not trying to trick you here. What do we see here? Yeah, yeah. Particularly any, what kind? He's got this B2, B2, B3, so probably anterior. I'm not trying to trick again with that. So STEMI, that's what our guy has here. So for EKG STEMI definition, I know I was talking to Glenn earlier. I know he did a talk for y'all on EKG, so I'm not going to go into too much depth, but probably good for us all to know the definition of a STEMI so we can identify it. This is whenever you have a new ST elevation at the J point, at least 1 millimeter and 2 contiguous leads. Unless it's V2, V3, in those cases, it needs to be a little bit higher depending on the gender. The J point, just to remind you, we have our complex here, where the S wave comes up and then turns into that ST segment. So you'll usually see a little bit of this, what is that, convexity, and that's the J point. That's where you want to measure for ST elevations. Now, if someone that's having a STEMI, you can see, or the EKG will evolve kind of as the STEMI progresses. Very, very early on, you'll see the hyperacute T waves that was with our as well as the ST elevation here. As it develops over the following hours and days, you're more likely to get Q waves. You'll get this complex there, that Q wave there, this downward sloping area. And then further on, we'll get T waves, which are more likely to stay on longer and can be a sign of prior ischemia. Apart from the guidelines here, so you get your ECG when you have this history of chest pain, and then this kind of show you your differential you're looking for based on the ECG. Of course, STEMI, we just talked about a little bit. You can get diffuse ST elevation. So if you see that across the board, that's consistent with pericarditis. ST depression in new T waves. We'll go into that in a little bit, but that can be consistent with the non-ST elevated ACS. So of course, if you have a new arrhythmia on there, you can treat that, find that and treat it. And then if you have a normal or non-diagnostic one, most likely you're going to repeat the ECG if the symptoms persist or change. Sometimes, I don't think I've ever even done this, but if you're still very suspicious for ischemia, you can actually shift around the leads and look for on the more posterior side. That's not something I've ever done, but apparently you can do it. I have learned. All right, so that's the ECG. The troponin, I'll say you get it, but if the ECG is diagnostic, you're not waiting. You call cardiology right away. They'll do that code STEMI. For a troponin to be positive, greater than 99th percentile upper reference limit, for us, for our institution, high sensitivity troponin, if it's initially non-diagnostic, that test is so good that if you test it again within an hour or two, if it's still negative, that has a very, very good sensitivity. If you have two within 2 hours that are negative, it's not ischemia from all studies we have. Very, very, very unlikely. Other biomarkers I remember learning about, we almost never use anymore. The CKMB and the myoglobin, really not beneficial anymore. Just stick with the high sensitivity troponin. All right, back to our case. Troponin 1,000 plus, even higher, was normal on admission. Of course, we diagnose STEMI, we call cardiology, and we hang the banner. Okay. Good job. All right, next case. 64-year-old female, history of hypertension, diabetes, COPD, comes in with acute on chronic dyspnea, symptoms worsening over the past few days. This morning, she felt like she couldn't catch her breath, so she came to the ER. The ED got a chest x-ray, questionable infiltrates on there. They diagnosed a COPD exacerbation and admit to us. Just because we're talking about the initial trope was 150, so not terribly, well, it's elevated. Are we done? What are we missing in this evaluation so far? Yeah, exactly, yeah. Make sure to check that whenever we have an elevated troponin or any of those symptoms that could be cardiac. So the ECG, let's see. ECG, no ST elevations. However, it does show T-wave inversions not seen on a previous ECG. And just to review, the T-wave inversions, of course, are these. So we get QRS complex and then this down slope after the fact, whereas normally it would be up. So in this case, any ideas on what this diagnosis could be? Not trying to trick. Yeah, non-ST, non-ST ACS or ACE elevation. Yeah. So non-ST elevated ACS includes the in-STEMI and also unstable angina. ECG findings that are fine. You have either new ST depressions, which don't need to be as big as the ST elevation, or these T-wave inversions. So stepping back for acute coronary syndrome, which includes the STEMI and in-STEMI that we've talked about so far, caused by a disruption of unstable coronary artery atherosclerotic plaque. So I really like this picture of it. So this plaque, usually pictured by yellow in the arteries, you get a disruption of it. So a disruption right here, rupture or erosion. You have activation of the coagulation cascade, which causes a thrombus, which causes decreased blood flow and ischemia downstream from that. That's our typical ACS. ACS, including those STEMI and STEMI. Important to note that this can be dynamic, so you can have someone that's initially unstable angina, and they can progress to in-STEMI and STEMI. So important to keep reassessing. So kind of saying more of the same here, just a different way. STEMI, typically a completely occlusive thrombus. Of course, we have our ST elevations, and the biomarkers, the troponins, will be positive. In STEMI, more likely, more often a partially occluded thrombus. You have the ST depression and T-wave inversions that should have talked about. For an in-STEMI, the troponin will be positive, unstable angina, troponin negative. This is the spectrum of ACS, essentially. So when we have acute MI, of course, the types, we hear type 1 and type 2. There's actually 5 or 6 types, but the ones that'll be relevant to us, type 1 and 2. Type 1 is this acute coronary thrombosis. So that's that plaque disruption and vessel thrombosis that I just mentioned. Type 2, which we get a lot of, probably more, we see more of, is caused by an imbalance between myocardial oxygen supply and demand, unrelated to coronary artery thrombosis. This seems out of order, but unstable angina, let's see. With unstable angina, we typically have just transient myocardial ischemia without significant breakdown of the heart muscle. Like we said, you have your typical symptoms where your troponin is negative and you may or may not have ECG changes. All right, management of ACS. Classically, what I learned, MONA, that's a very traditional treatment for ACS, morphine, oxygen, nitro, and aspirin. This is probably outdated now. Oxygen not been shown to improve outcomes unless someone is actually hypoxic. If they are actually legitimately hypoxic, then you add oxygen. But you don't need to put it on them for no reason. Morphine and nitro certainly help symptoms, but not clinical outcomes. Aspirin, of course, we still use. So I actually like going through some of the other management, and then there's a different mnemonic that I like using instead, or that I found that I like. Generally, we'll treat with DAP, so you get your aspirin, your Tycag, Plavix, all these things. The DAP should have shown to reduce the events. These people will be on therapeutic heparin drips until revascularization, or if they're not going to be revascularized, then usually 2 or 3 days, depending on what cardiology wants. Be on a statin, and it's something that I need to do better at, following up this LDL level, and we need to aggressively be treating these. So if they're on a statin and that LDL is still high, we really should be adding a non-statin agent to try and get that down lower. Beta blocker, very, very good at helping to reduce the risk of reinfarction or ventricular arrhythmias, of which they are at high risk for within 24 hours. So we try and get these people on a beta blocker as soon as possible. And then the RAS inhibitors, less important right away unless we have one of these other problems with something else in the history reason for it. Skipped right through it. So one thing that the mnemonic that I found that I liked is thrombins. So T, that's phenopyridine, basically the other oral antiplatelet agents. H for heparin, R is the RAS system to consider, O oxygen, M for morphine, B beta blocker, I, you're going to revascularize, you're going to intervene, N nitroglycerin, and S for statin and salicylate, which is aspirin. So thrombins, I like. Of course, in these people, we're going to consult cardiology after we diagnose ACS and generally going to cath. With N-STEMI, so not ST elevated ACS, one of the things the guidelines talked about is routine versus selective. So routine versus delaying basically a cath. The guidelines say at routine, we should be cathing these people if there's any sign of ACS, lower rates of recurrent MI and ischemia. I think I talked about it right here. Yeah, so with the selective invasive approach, so if there are reasons potentially they can't be cathed or there's contraindications to cath, we can use certain scores to help risk stratify and help us, weigh the pros and cons. The Grace and Timmy score we don't need to go over, but you can find a calculator for those and can give you an idea of the risk of not intervening on these patients. Can be helpful to use when we have some of these contraindications, high risk of bleeding, thrombocytopenia, renal disease, limited life expectancy, dementia, something that we know we can't fix in the anatomy, and certainly if the patient really doesn't want a cath. Okay, all right, case 3. Yeah. Okay. This one is actually a case from my chalk talk, if anyone listened to that a couple weeks ago. 52-year-old female, intermittent non-exertional chest pain, 3 months, more severe episode prompting an ER visit. History, hypertension, diabetes, tobacco, medications, non-specific EKG findings, and tropes are negative ×2. Next step, I will give it, this person's coming into the ER. They are going to, of course, admit to us because it's our ER. I say that what they do, we can actually use in these patients that have typical symptoms or have some kind of risk, or we're not really sure what to do with. We can use CDPs, clinical decision pathways, to kind of help guide what we're doing. And basically, what these are the calculators that can help us determine whether people are low, intermediate, or high risk. Can help us avoid admission, supposedly not in our hospital. But the big one we use is heart. So history, EKG, age, risk factors, and troponin. All right, so this, I didn't go into it in my last talk, but this one, it's worth knowing what the ER is looking at. It's a heart score, 5 things: history, ECG, age, risk factors, and troponin. Each one 0 to 2 scores. It's actually very easy to calculate. If you do add it all up, of course, low risk generally can be discharged. High risk, generally they're going to call cardiology and cath, but we always get these moderate risk people where there's not insignificant risk of something happening to them over the next 6 weeks, and so they get admitted to us to decide what to do with them. I think kind of like the same thing I just said. Low risk generally can be discharged, and nothing else really. Of course, you're always going to correct cardiac risk factors. High risk, like I said, they're going to be cath. Intermediate risk, lots of options on what to do. We can do, and it's kind of sometimes can be hard to know what the right next step is. So echo, we get a cardiac CT, MRI. Do we still cath these people? Stress test or discharge them? There's some great charts here I'm going to get to in the guidelines that kind of can help guide us in these. And these are our typical chest pain admissions. So first, just going to briefly go through just to remind what each of these does and when we can and can't use them. Echo, of course, quickly assess function for wall motion abnormalities, effusion. And I highlighted quickly there because it's still here, takes 24 to 48 hours. It's not supposed to be that way, but in theory, echo can quickly give us a lot of information. Exercise EKG. Of course, graded exercise until fatigue, chest pain, or they see ischemia. Contraindications, not going to read all that, but if they have an abnormal EKG at baseline, or they have significant cardiac arrhythmias, or if they're sick, or if they can't exercise, obviously we can't do those. Stress echo, similarly, just we're similar to the EKG, except we're monitoring with the with an echocardiogram. Stress echo, safe and effective to use. Skipping through the numbers. Contraindications, really need to be able to get good acoustic windows. And again, really they can't be acutely ill. They need to be able to tolerate the test. Nuclear stress test or myocardial perfusion imaging. This is a big one that we use here. Of course, can detect perfusion abnormalities, measure LV function, and look for other high-risk findings. Contraindications, of course, severe arrhythmias, hypotension, bronchoconstrictive disease, severe hypertension. Some more on the stress test. A stress test with, let's see, lost my train of thought here. Oh, so just showing that stress test is okay. Stress test compared with CCTA, both are equally effective in reducing long-term or reducing the risk of MACE at follow-up. However, the stress test does tend to delay time to diagnosis by a good bit compared with the coronary CTA. So talking about our coronary CT, I'll just say CT here. Very helpful, can visualize the extent and severity of non-obstructive and obstructive CAD, as well as you can get the plaque composition and look for other high-risk features. You can also use it to calculate this FFRCT, which can actually estimate lesion-specific ischemia. You'll see this is one that I wasn't very familiar with, but in these, whatever they're called, the guidelines have these great charts that they actually you can incorporate this into deciding what to do with patients. Contraindications for that, renal impairment, contrast, allergy. More on the CT. Found that in the ED evaluation of patients with acute chest pain, CT can reduce the time to diagnosis, kind of as I said before, without impacting safety. Okay. Hey, this is more.
Okay.
Okay.
Yeah.
On you, see where you have it.
Very distractible. I think I included a lot of trials here. So CT good at reducing the risk of events in long term. Similar, reduction of MACE in long term. Let's see. CT and stress echo good at reducing MACE. Again, we don't need to go through all those. They're good at detecting things. Another trial, this one I like, so this one compared the use of CT to stress test. Again, time to diagnosis, generally much less in the CT compared to the stress testing. Again, I wonder where they did these because this certainly wouldn't be here, but in theory, again, CT can be very good and quick. It also reduces costs by almost, there you go, $680 per time per presentation. So still, just like I did a couple weeks ago, just on this time, I'm making the case that we need to do more cardiac CTs. Let's see, I think cardiac MRI, we're getting towards the end of all these. Assess global function, detect ischemia, and all these things that all the rest of them do. It also help determine myocardial viability. Can also, there you go, detect myocardial edema, microvascular obstruction, which can help distinguish between acute and chronic MI. And then I like this one. It can actually sometimes if we get someone comes in with ACS, they cath them, they don't find anything, we can actually get evidence of Minoco, which is MI with non-obstructive CAD, but we can see evidence of that on CMR. Contraindications are the ones for MRI. All right, then of course, cathing them, coronary angiography. For intermediate risk patients, this is from the guidelines, with a previous history of CAD and frequent symptoms, and you've already added them on GDT, they recommend, or they say it's reasonable to take these people for cath. So I feel like that's a good bit of our patient population where frequent flyers coming in with chest pain that haven't been cath recently, it's reasonable to cath them. All right, summarize the last few slides. Just kidding. This is Liam. Here's a little break. He's adorable. I'm shamelessly using him to get attention for these next few slides. That's one of the best smiles ever. I love it.
So cool.
He is so cool. Apparently, he got a hat too for this one for a little bit, and it fell off.
Aw.
Yes, he loves playing in the pool, and he's about to be a big brother. Just a couple of weeks. Okay, so now that I have your attention again, we're going to go through some of the guidelines. So which of these tests do we use? And so going through some of these charts, this one, we're not going to go through all of it at once. I can't even see the top there. Okay, well, I don't want to mess this up by getting rid of that. There we go. Okay. These charts are going to go through a couple of different case scenarios. So these are the ones that we can use and if we have different situations. So if someone's with, you're concerned for coronary artery disease, but you have a pretest likelihood, which I'll go through in a second. If it's low, no testing needed. If you're intermediate to high risk. And generally, if your patient's younger or you're suspecting less obstructive disease, CCTA is great at that and finding out how much non-obstructive disease we might have. Generally, older patients, or if there already is obstructive CAD and you want to figure out how the functional effect of that, we'll get stress testing or prefer stress testing. Kind of more of the same here, just comparing CT and stress imaging. CCTA good, again, obstructive and non-obstructive, better for younger patients. Important if they have recent or prior functional studies that were not helpful, get a CCTA instead. Stress imaging, of course, is more functional. We can see functional issues, generally better with a older, if you have a prior CT that's inconclusive. And then also, if we know we have prior disease or a prior scar, we can see basically how much we think is scar versus ischemia. And then this bottom one, I didn't really actually get all that much from, so we're gonna skip that. All right, so these are the charts I like. This one, so that's acute chest pain, intermediate risk. So that heart score of 4 to 6. If you have no known CAD. I mean, you can really take this chart and go down it. So let me think of an example. I actually just took care of a patient this week who came in acute chest pain, kind of episodes over the last couple of weeks, but came in after a more severe episode, no known history of CAD, so no prior testing. It is recommended you can do either stress testing or CTA. Either one is okay in these situations. So we got a stress test. It was negative. We discharged. All right, was that easy? Another example, you do have prior testing, say, if that test is recent, discharge. Inconclusive, here they use stress tests here, CCTA, etc. I'm not going to go through all the different guidelines, but I found this really helpful to look at to see, hey, what information do we have and what can be the next step. And just as an example of that FFRCT I mentioned before, can be helpful to get a CCTA because it gives us this data that can show whether the obstructive disease is significant. And almost all of these, right, will result in either adding GDMT and discharging or eventually going for cath. All right, so similarly, if we have known coronary artery disease. Can't really get this out of the way enough. Of course, if we know it's non-obstructive, more likely for CT, obstructive, more likely to get stress testing. Again, not going to go all the way down here, but it can guide you as you're giving these tests on what to do with these patients. One of the good questions that they answer is when we need to retest. So these people that come back, they get a stress test, or they get a CT, or they get a cath, and it's normal. How good is that good for? When do we need to repeat those tests? When symptoms are unchanged and we have normal angiography or normal CT, 2 years. That's good for 2 years. If the symptoms are unchanged, we don't need to re-image or re-cath these people for up to 2 years. We probably do that more frequently than we should. Stress tests only good for 1 year. That's because the stress test doesn't show us if we have significant plaque that may cause problems sooner. All right, let's see, we've gone through all of ACS, we've gone through the intermediate risk. So stable angina, these chronic chest pains. Like I said before, symptoms are chronic, associated with consistent precipitants. What you will generally do, and a lot of this will be outpatient. We'll commonly get these patients still admitted to us, of course, or they might be coming in with someone else, and we're trying to figure out how to treat their stable angina. So first thing you want to do is determine the pretest probability of an obstructive disease. There's different ways you can do this, but I like this chart from these guidelines that can give you an idea of the risk of CAD based on age, symptoms, and gender. You can go obviously low to high risk there. Once you have that, we have more of these charts. So chest pain, no known CAD, you get that clinical risk assessment, and then you follow down the guidelines here. And again, there's no point in reading each individual thing here, but these are, I want you to know that they're out there and very thorough and helpful. Similarly, if they have known CAD, it's kind of similar to the other one. But again, it can help guide you through what you need to do. All right. Case 4. I believe this is the last case I did. 73-year-old male, history dementia, hypertension, GERD, CAD, AAA, metastatic colon cancer, admitted for melanoma. That sound familiar? GI consulted, they performed endoscopy, found a gastric ulcer, treated it. That afternoon after the procedure, complains of acute chest pain. This is cross cover page. This patient, acute chest pain, you go and see the patient. They are, of course, delirious and not able to help you much. They just say, I hurt. I want you to stop it, doc. Let's see, what did I say? Tachycardic, breathing comfortably on 2 liters. Without being able to get much history, what is our differential? I mean, and this is a very broad. I kind of asked this jokingly because just because of how much there could be there. So important in this case, you want to rule out, or you want to think about the causes, the emergency causes of chest pain, or the etiologies that would warrant an emergency. Of course, ACS we've talked about, but aortic dissection, pulmonary embolism, esophageal rupture, pneumothorax. Generally the ones you want to be able to rule out, and when you're thinking about how to work it up. Let's see, this is going to get boring. Let's see, the other way I think about this. So once you think about the emergency causes, you say, hey, none of these are likely, or you rule those out. Broad differential for chest pain, breaking it down by system can help. And so I'll say these last couple slides are listing differential. I don't have time to go into all of those, obviously, but thinking about the heart, outside of ACS, pericarditis, pericardial effusion, angina. Respiratory causes, you got your PE, pneumothorax, infection, GI causes, cholecystitis, pancreatitis, etc., esophagitis, spasm. More differential chest wall stuff, chest wall pain, MSK, shingles. Differential is broad. Of course, psychological, panic, anxiety, substance use. somatic disorder. Even more, some less likely things. Just to have it out there. These cases, it can be important. The physical exam can help guide you as to what direction to think about. Of course, in ACS, we talked about uncomfortable, diaphoretic, dyspneic, pale. If someone has chest tenderness or pain with inspiration, less likely ACS. Some of the important non-cardiac causes and their physical exam findings. We're going to do a little game here. Check for limb pulse differential. The way I did this, I had to get all these out, and then we'll go through and say what these are. So tachycardia, dyspnea, murmurs, friction rub, painful tympanic abdomen. Okay, so each of these has a diagnosis. Limb pulse differential. What is that? What would that make you think of? Yeah, I already said that. This next one, these are classic buzzwords: tachycardia, dyspnea, P2. Yeah, yeah. Murmurs, pulse alterations. So someone has a murmur that wasn't there before. Yeah, that's structural heart things. Friction rub, symptoms worse wings of time. Pericarditis, yeah. Painful tympanic abdomen or any kind of abdominal symptoms. Yeah, that's your acute abdomen. So really any GI things. Yeah, esophageal rupture, I guess in our guy's case, but really any of those GI things. Absence of breath sounds. Yeah. Rash and chest pain. Doctor. Yeah. All right, there's just some of the things you can look for to help diagnose chest pain. So generally, this is just my summary of what I would probably do in this. You're going to obviously get ECG and troponins, a chest X-ray can assess obviously for all the lung stuff, and echo can quickly rule out a lot of the emergency heart that quickly rule out a lot of that stuff. And then a CT or CTA can add on the abdomen and pelvis for any of those GI pathologies. So usually if you get all these things, you're going to rule out almost or look for almost everything for chest pain. All right, and diagnosis, I didn't want to come up with something. Could be any of the above, whatever. Some last couple notes here. We sometimes would take care of patients that have had CABG. MSK pain is still the most common. And then there's also this post-sternotomy pain syndrome, which can happen if people are still having pain over 2 months after without another obvious cause. We can attribute it to this post-sternotomy pain syndrome. That is a very wide range incidence, but there we go. Dialysis patients frequently have chest pain on dialysis. They commonly have severe cardiovascular disease. I guess that's all there is to that. And then substance use, of course, very frequently have chest pain, cocaine and meth users. But the frequency of ACS is, say, rare, less than 10%, is still fairly common, but death is rare. Chest pain and substance use makes me think less about ACS.